Okay, so we are joined by Ryan Skolnick, which I hope I'm saying correctly, who is a community organizer for the California Nurses Association, and the National Nurses Organizing Committee. Since 2017, Skolnick has been working for the single-payer health care projects. So in their variety of incarnations, such as SB 562, and currently he will be speaking to us about CalCare. So without further ado, Ryan.
Thanks so much, Ray and Glenn, for having me. Happy to be presenting to you all. Like Ray said, my name is Ryan Skolnick, proud to be a community organizer with CNA. Before I get started, I did want to ask, just so I can most optimize our time, is this a group that feels fairly comfortable about what single-payer healthcare and CalCare are? Or would it be helpful if I kind of gave some background as to what the proposal is before talking about this specific effort?
I think it's always a good idea to give a basic background, because even if the people here may not know that, that's probably helpful for anyone who comes across the video. And it's also just, I think, good practice to be on the same page about what we're actually talking about.
Yeah, of course. I've had people say, why are you wasting time with all the background? We know this already. So I do tend to like to check. Cool. So what I will do in that case is I'll start with a very brief, and I emphasize brief, overview of the problem with our healthcare system, because I don't think it needs too much explaining. Explain how CalCare will fix those problems, give a short update about what the campaign looks like right now, and then hopefully have time for Q&A. So our current system has several major problems, needless to say. And I like to frame the problems with our healthcare system in the lens of what are called the 7 CalCare principles. So when we talk about what CalCare, the California Guaranteed Healthcare for All Act, is, we like to frame it in the form of 7 principles that correspond with what the bill does, but also that correspond with 7 problems that exist in our current healthcare system. So what I'm going to do is I'm going to go through each problem and then connect it to one of those CalCare principles. So you can kind of get a sense of how CalCare would change our current system. So the first and most obvious problem with our healthcare system is that it doesn't cover everyone. Far from it. Even now, after all the expansion that we've done in the state of California, there are still 3 million Californians that have no health insurance at all. That is a number that is inexcusable for, I believe we're the 4th or 5th currently largest economy in the world. That certainly has the financial resources to guarantee care to everybody, but there are 3 million people who don't have coverage. And to be clear, this is just people who don't even have the ability to pay the premiums to get the care. As I'm going to talk about in a minute, coverage alone doesn't guarantee you can get the care you need. So we're starting off with 3 million people that have no coverage whatsoever, which means that they probably almost certainly cannot afford to get care because out of pocket is prohibitively expensive. And that connects to the first CalCare principle, which is universal coverage. We like to say in the single payer movement, everybody in, nobody out. Under CalCare, everybody in the state is guaranteed health care from the moment they enter this world into the moment they leave it. All residents of the state are beneficiaries of the program. The second problem with our healthcare system is, and this ties into a few different things, but this is the second most obvious, it's absurdly expensive, both on the individual and the system level. And there are many reasons for it, but the major reason is fragmentation. And I like to look at it from the view of what are called risk pools. So the more in this country, you have a bunch of different insurance companies. Those insurance companies offer different plans to different people in different parts of the country and even different parts of the state that offer different coverages. They offer different levels of cost sharing. You have gold, silver, and platinum plans on the ACA, bronze, silver, and gold plans on the ACA exchanges. You go to your job or your private insurance market, to buy an insurance plan and you see phrases like HMO, PPO, and then several different options of those. And it's all really confusing. This all contributes to making our system more expensive because the more pools of money, insurance plans you have out there that are covering small groups of people, the more expensive it is to pay for each of those systems to pay. And let me give you a visual of what that looks like. Let's say that Glenn and I are the only two people who are in one health insurance pool, and we're both paying our premiums, and I break my arm and I need a surgery. And that surgery costs $5,000. It will take $2,500 in premiums from Glenn and I to pay for my surgery. You add two more people to that same pool of money. Now, all of a sudden, it takes $1,250 from each of us. So you take that principle and add as many people as possible into one pool of money, one plan, and you make it much more affordable to cover everyone. That's why the second principle of CalCare is a single public program, a single payer. This would implement one single state-administered insurance plan that would cover everyone in the state with guaranteed high-quality healthcare. That's why we're able to, as I'll talk about in a minute, not only cover everybody, but also expand benefits and save cost over our current system because we eliminate the bloat and fragmentation in our system and make things more efficient with one guaranteed plan. The third problem with our healthcare system is that when people do have healthcare, there are a lot of critical services that most rational people would consider healthcare that just aren't covered. For example, how many people think it makes sense that dental care isn't included with your standard healthcare plan and that you have to pay separately for it? Or long-term care, which is becoming more and more important. Those things are not included in your standard insurance plan, not because they're not health related, but because they're not profitable to cover. That's why they're not included. Long-term care in particular, because that is a sort of care that by definition is chronic. It's not something that you just do once and it's over with. It requires ongoing services, oftentimes several times a day. For some people, that is extremely expensive and not profitable to cover, which is why when you have a market system like we currently do, it's not going to end up covered. That's why the third principle of CalCare is fully comprehensive benefits, as determined, by the way, by your doctor. Under our current system, your doctor often doesn't even have the final say over whether you get care or not. It's often an insurance company claims administrator who has no experience in medicine deciding whether you can get treatment or not based on whether it's needed, but whether it's profitable for the company or not. Under CalCare, since we get rid of the insurance company middlemen, the decision maker in this process here is your doctor. The system establishes a comprehensive set of benefits in law. If your doctor determines that you need care that falls under the umbrella of one of those benefits, the state isn't going to overrule the doctor because the doctor knows best. That's how the healthcare system should work. People who know medicine should be in charge of making medical decisions. The fourth problem is that as much as people like to complain about what single payer healthcare might do, our current system is not free at all. And I'll give you the biggest example, which is you don't often have a say over what doctor or hospital you go to. Your insurance company does. They tell you, here is the small pool of doctors and hospitals that we will pay for you to go to. You can go to another one if you want, but you'll have to pay for it yourself. That's also due to profit. How it works is insurance companies will go to doctors or individuals or doctor groups and say, if you are willing to take less money from us, we will add you to our network. And that means that you are guaranteed access to all of our subscribers. It's a good deal for doctors, so they often say yes. And that's what determines your network, based on who insurance companies can negotiate the lowest reimbursement rates for, not based on quality and not based on need. That doesn't exist under CalCare. The fourth CalCare principle is freedom to choose your care provider. There are no limited networks under CalCare. So you can see any practicing provider in the state of California under CalCare. The fifth problem, and I alluded to this earlier on, is even when you do have insurance, you often can't afford to use it because you have to pay a copay every time you go to the doctor. You might have to meet a deductible, high deductible plans where you have to sometimes pay as much as $10,000 out of pocket before your insurance even kicks in for a lot of services. They're becoming more and more common. There's a phrase for that as well. That's called underinsurance, where you have insurance, but you can't afford to use it because your current plan is too expensive. That doesn't exist under CalCare either because CalCare eliminates all cost sharing at the point of service,
Right.
which means that you go to the doctor, you get the care you need. It's all paid for on the back end. Your ability to pay at the when you need care is never a determinant of whether you can get that care or not under CalCare. The sixth problem is and this is kind of more of a macro issue as opposed to a specific problem, well, actually, I'm going to go ahead and skip this one for a minute. I'm going to go to this next one because it might require a little bit more expectation. The next problem is that under our current system, doctors are increasingly being pitted against patients. And here's what I mean by that. Under the current system of healthcare, and this is particularly true in California, because this is a very, very ubiquitous trend here. We are moving towards reimbursement models for doctors that pit their financial gain against patient interest. They're broadly called value-based payments, but there are certain different types of payments within that umbrella, and they incentivize doctors to prioritize their bottom line over patients. And even when you have ethical doctors, this isn't a structure we should have in our system. And I'll give you an example. One very common form of reimbursement that's become more and more common is called capitation. Capitation is where you'll have a doctor or a doctor group you'll have a doctor group that will receive a set amount of money from a payer, whether it's an insurance company or Medicare or whatever, and they will say, for each number of people that you routinely take care of, you'll get X amount of dollars. And whatever you don't spend on care, you can keep. They encourage you to reduce health. They're trying to lower healthcare costs by telling doctors you can share in the savings of cost savings if you don't spend as much money on healthcare. That is a direct incentive to not provide expensive and necessary care. It's also an incentive to not take certain types of patients, namely patients who have chronic conditions or patients who are more likely to develop chronic conditions. So these sorts of payment models are becoming more and more common. It's, like I said, especially in California, where our Medi-Cal system is moving full-heartedly into what it's called managed care, which uses these alternative payment models. CalCare gets rid of those. CalCare's sixth principle is patient care based on patient need, which means that what the patient needs to become healthy should be the foremost consideration, not profit. We eliminate reimbursement models that pit patients and providers against each other, because that isn't a reasonable way to run a system, encouraging less care. We should be doing the opposite. And then the final principle of CalCare, this isn't necessarily tied to a specific problem with the current system, but this is more a reality of what we want to accomplish by moving to CalCare, is a just transition for workers whose jobs would be impacted by the transition to CalCare. Because we want to leave the current system of for-profit insurance in the past. What we don't want to do is leave the workers who are just trying to make a living behind. It's not their fault that the system is terrible. So for the first 5 years of the CalCare program's implementation, at least 1% of its total budget, which is a multi-billion-dollar fund, would be set aside specifically to help with programs meant for people whose jobs are impacted by the transition to CalCare. And that could take several forms. That could take the form of, if they want to learn a new trade, tuition reimbursement or job placement. They want to retire early, it can be early retirement. If they need help while finding a new job, it can be in the form of gap wages. There's a lot of different forms that can take, and it can be tailored. But making sure that everyone is brought along and no one's left behind, with the exception of for-profit healthcare, no one's left behind by this transition is a very important concept for us. So universal coverage, a single public program, fully comprehensive benefits, freedom to choose your care provider, free at the point of service, a just transition, and patient care based on patient need. Those are the 7 principles of CalCare. And those are embodied in the CalCare proposal that we are going to, starting next year, really push. And that leads me give you a really quick update about what the campaign looks like right now. So, like was mentioned at the beginning, CNA has been fighting for single payer for a long time. CNA itself has actually been fighting for single payer since the early 90s, when it led a ballot initiative, Prop 187, which would have implemented a single payer healthcare system here. And unfortunately, that failed. But they've never stopped. There was a bill in 2017 that was mentioned when I was introduced, SB 562. There was another bill last cycle, 2021-22. That was the first itineration that was called CalCare, and that was in the form of Assembly Bill 1400, which was one of the most detailed single-payer bills that has ever been introduced at the state level, and it would have implemented all 7 of the principles that I just talked about. We were able to get that bill through the Assembly Health and Appropriations Committees, and we even secured the support of Speaker Rendon, who was a staunch opponent of the 2017 bill. Unfortunately, the bill didn't have the votes it needed to pass on the House Assembly floor, and it was pulled from a vote. So we were disappointed, but we've been organizing ever since. We decided to change up our tactics a little bit. So at the beginning of this year, we had conversations with legislators who told us we were open to CalCare, but we felt rushed. We felt like we didn't have enough time to engage on the substance of the bill. The bill was held for all of a year when it was first introduced, and all of a sudden, at the beginning of 2022, it just started moving, and we didn't have time to really just talk about it, so we want to wait. So we said, okay, so here's what we'll do. We'll introduce what's called a spot bill, meaning it's a bill that doesn't have substance in it. It's a placeholder. And that bill is Assembly Bill 1690 for this cycle. It's a spot bill that states the legislature's intention to do CalCare. We've been using that bill to build support outside of the legislature, while also using it to have conversations with legislators that they said they wanted before voting it on the inside. So we've been doing those things. And we are getting ready to reintroduce a new CalCare bill in 2024, the beginning of the year. And it's going to have the full substance of the proposal. The proposal, if anyone is into reading legislation and wants to know what specifically it will look like, if you look up AB 1400 from last cycle, it's going to be very similar to that. Changes may or may not come based on what legislators have to say, but it's going to be substantially similar to that model. And the bill, like I said, embodies the principles of CalCare, and it will fix many of the horrible problems with our healthcare system. In order to build support in the meantime, we've been doing a lot of different things. I'm going to give you a few, and then I'm going to give you some calls to action if you are interested in getting involved that I'd love if people would do. And then we can, and then I can take some questions if time permits. So the crux of our campaign, and we're very happy we were able to do this because we weren't able to for AB 1400 because there was the peak of the pandemic. We've returned to canvassing. We've been doing monthly canvasses, both door to door and crowd canvassing, where we've been gathering petition signatures, more on that in a second, and having conversations with people about CalCare, kind of introducing them, because we understand that it's going to take a lot of popular support to make CalCare happen. Polling has showed that the majority of the public supports single-payer healthcare, but it also shows that they really don't pay much attention to it and they're not super engaged. So our job is to take people who like the idea and turn them into activists. And that's what we're hoping to do with our canvassing.
If I might add just there for the local folks, I've been doing some crowd canvases in Felton and Boulder Creek, and Ginny Schwingle and Sally Gwynn Satterley have been doing them in Santa Cruz. So there's plenty of opportunities to do that here.
Yep, and we're very thankful you've been doing that as well, Glenn. I'm going to put my first link in the chat right now. This is a link to our events map. And at the end of every month, you'll be able to put in your zip code and you'll find if there are any canvases going on near you, and you can sign up for them using that link. So that's the first thing that we've been doing. The next thing that I want to mention that we've been doing is petition gathering. So this petition, we've been circulating a CalCare petition that we're going to be submitting signatures from to the legislature in the lead up to the introduction of CalCare. We want to make it very clear to the legislature that this is not an issue that's faded, that there is a very engaged and active constituency that wants to see this happen. And the thing is, a lot of legislators tend to prioritize different things based on where they perceive their base to be. So in order for them to move on something as big as CalCare, they need to be convinced that there is a serious demand for it. And that's sort of what the petition we're hoping to help fill. So if anyone hasn't signed this petition yet, I'm going to put the link to that, which is calcarepetition.org, in the chat. Feel free to sign that petition as well. Now, my next call to action is actually my next two calls to action are actually for the club itself. I understand if you need to agendize this for another time, but we'd be very thankful if you would, is sign what's called our organization endorsement form. So our organization endorsement form is a form that we ask organizations to sign that endorse the CalCare campaign. We're not asking for a specific endorsement of a bill right now because CalCare is currently a spot bill. This is a commitment to support the campaign to pass CalCare as outlined in its 7 principles. So we have been organizing organizations to send, for the time when the bill is introduced, to send support letters in. And we also have established what's called the CalCare organizing table, which we've been having meetings to focus primarily on field organizing. We're planning a big day of action in September. So if your organization is willing to sign on as an organizational supporter of CalCare, then voting as a body to sign the petition at the link I just sent would accomplish that. And then if you vote to do that, and you decide to that you would like to join the field organizing effort, if you check collaborate on field organizing at the petition when you sign it, that will let us know that you're interested in joining the org endorsement on the org table. And then we would send you an invite if that is checked. That is a table that we have specifically for organizing, though. So it's only for people who are willing to do that sort of work. But if you would be willing to plug into that and maybe send a representative to that table, then that would be how you would check. And then my final call to action is actually a lot more time sensitive. Actually, I have 2 more. This one is very time sensitive. We are having a town hall, a CalCare town hall in San Jose, which I believe is 45 minutes to an hour away from you all. And that's going to be happening on Wednesday, the 19th at 6 p.m. It's going to be hosted by one of my coworkers, Riley Brand. Assemblymember Ash Kalra is going to be there, as well as Senator David Cortese. And it's going to be a panel discussion on CalCare and how important it is for various communities. We're doing one in San Jose, one in Santa Rosa, one in Oakland, and one in Los Angeles. The San Jose one is the 19th. So if anyone is interested in attending, this would be the link. And also, I'd be very thankful if your organization would be willing to promote that event to anyone in the community that you feel like might be interested in going. This is an in-person event, so it would require physical attendance. But if you know people who are interested, we'd be very thankful if you'd help recruit. And then finally, if you know anyone who might be interested in CalCare but wants to learn more about CalCare and about the campaign before plugging in thoroughly, we have a series of CalCare 101 calls where we talk a lot about what I just talked about, the basics of CalCare and the basics of the problems with our healthcare system, talks about the campaign, basically a longer version of the conversation I'm having with you now. So if anyone's interested in that, I'm going to put a Zoom registration link in the chat. And if you'd be willing to share that with anyone that you feel like might be interested in learning more. The next one is August 17th, so there's some time, but those are all different ways that if you're interested, you can plug into the campaign. I know I've taken up a little bit of time. So I will go ahead and if time permits, take questions. And I'm very thankful that I've had the opportunity to present to you all. These sorts of conversations are how we're going to build the support we need, is to have this kind of engagement. So thank you again.
Thank you, Ryan. And Ray, can we send out some of this stuff in the newsletter?
Of course.
I'm sure we can figure that out. I'm on board with it. I think we should discuss as a group. I see that Tim has a question. I would like a little clarification first. So I lived in a country that had single payer healthcare, and it coexisted with private health systems. And it was kind of great in a way because it competed with private health systems, but that's not always the model. So do you see this as being something that would limit or compete with a private healthcare system? Should people still want that? Should there be needs?
Do you mind if I ask what country that you're talking about?
Yeah, Argentina.
Okay. So I'm not quite sure what regulation they have in place on the private companies, but if you were to simply implement a public system to compete with the private system here without severely curtailing the sorts of activities that the private insurance sector could do, you would end up with a problem like what the NHS in the UK is dealing with right now. That's called tiered healthcare. So what happens is the private system in the UK will offer perks that the public system isn't going to pay for. Things like priority placement in certain or better rooms, or certain procedures that aren't necessary but people want. So what happens is, since they're private, they often benefit from capital investment. They're able to reimburse doctors at a higher rate than the public system is going to do, which in CalCare's case would be Medicare rates. So what would happen in that case is you'd drive up wait times and reduce quality for everyone in the main system, as more and more providers prioritize the higher cost patients in the private system. That's why NHS wait times are skyrocketing and quality is decreasing. As they move more and more towards allowing private insurance and private plans to compete, that's where you're seeing a lot of these problems. So in terms of what CalCare would specifically do, it would allow for private insurance that doesn't duplicate the benefits of CalCare, but to the furthest extent possible, it wouldn't allow for private insurance to offer plans that compete with the CalCare system, specifically because you don't want that issue of tiered healthcare, where people who can afford to pay more get better care than people who don't, if that makes sense.
More like supplemental than competitive.
Okay, so on that sort of related to that, yeah, no problem. So I know this is not, it hasn't been specifically drawn out yet, and you mentioned the 5-year transition period, but what is likely to happen to current hospitals and clinics? For example, we have these brand new Kaiser Permanente clinics out here. What happens to those now that it's moving towards a single payer?
So that's a 2-part question. You have the question about hospitals in general, and then Kaiser specifically, which is a little unique. So hospitals under CalCare are what are called an institutional provider. And institutional providers under CalCare are reimbursed with a mechanism called a global budget, which means that the hospital would sit down with the CalCare system and say, this is the demographic that we service. These are the health issues they typically have. These are the services that we typically provide. This is the what foot traffic looks like. This is our equipment, et cetera, et cetera. And that would result in a negotiation with the system for a lump sum payment to cover all of their quarterly operating expenses. And the primary benefit to that is it's a more stable and equitable financing source than exists in the current system. This is a big deal for smaller and more rural hospitals, because under the current system, where a lot of capital is dependent on foot traffic, those hospitals are bleeding cash, and as many as a third of them are at risk of closure right now. Under CalCare, global budgets are tailored towards that specific hospital's needs. So it's a stabilizer. It's a way to ensure that hospitals don't close. This also applies not just to rural, but also hospitals that serve medically underserved people in inner cities and stuff. Basically, it would ensure that hospitals that don't serve the rich would have access to enough capital to continue to stay open and provide care. Now, as far as Kaiser, this is a question I hear all the time. When people say Kaiser Permanente, they're actually talking about 3 individual organizations under one umbrella. Because you have with Kaiser, the Kaiser Health Plans, the Kaiser Foundation Hospitals, and the Permanente Medical Groups. There are 3 distinct organizations that coordinate and cooperate with each other and under the umbrella title of Kaiser Permanente. CalCare doesn't impact the doctors or the hospitals. They still exist and provide care. What it does is it takes the insurance plans away. It basically says, Kaiser, you can continue to coordinate care and provide care and talk to each other, and we'll even reimburse you for time you spend coordinating with each other. But what you can't do is offer competing insurance plans. So what does that look like for people who have Kaiser? Well, people who currently have Kaiser, the only thing they're going to notice is that they're now able to go outside of Kaiser if they want to for care elsewhere, because they're no longer locked into the HMO model by the insurance plan. They could still see Kaiser doctors, they just have a choice. Meanwhile, for everyone who doesn't have Kaiser, they can now go to Kaiser because it's not a locked down HMO where only members can access it. So Kaiser would still exist, it just wouldn't be offering an insurance plan, if that makes sense.
Yeah, that makes sense. Tim.
Yeah, I have a couple of questions. First of all, I wanted to compliment you because we had a presentation about CalCare, 3-4 years ago, quite a long time ago. And at that time, there just weren't these kinds of details.
Yes.
So that you're giving us. So thank you. It sounds like you've really worked on this. So my first question is, if I go look at AB 14, the kinds of things that you just talked about, are they in there?
Yeah.
Like what would happen with Kaiser, things like that?
Well, it is in there. It doesn't specifically say Kaiser, but it would say how institutional providers are reimbursed. Global budgets are in there. And then, what I told you from Kaiser comes from 2 different parts of the bill. One is the compete clause, which says that private insurance offerings can't offer duplicating benefits to the single payer system, which is why the insurance plans would go away, because it's not profitable to run them if they can't offer benefits that compete with the single payer. And then the global budgets, the institutional providers, is how they would continue to be reimbursed. So they are in there. You just need to know what you're looking for.
Okay, great. Yeah, because I noticed, I went back and looked, and last year the what you call the spot bill didn't go anywhere. And the only information about it was the issue about Kaiser. Kaiser came up, and the question was what would happen to its 110,000 employees. So, and I see you've got 1% for some of them already baked into the system. But that leads me to the second question is, so you're doing this signature gathering. Am I correct to assume that the signature gathering is for the actual CalCare bill for 2024 and not for the spot bill for this year? Is that correct?
So the CalCare petition website doesn't specify a specific bill because we're not going to tell people that they should be calling their legislators about a spot bill, because it's there as a placeholder. What the petition says is I call on the legislature to pass the California Guaranteed Healthcare for All Act, which is what the bill next year is going to be. It's sort of like the org endorsement form, where you're endorsing the concept of CalCare. And then on the petition, we link to the 7 principles I talked about. So you're more endorsing what CalCare is going to be rather than a specific bill right now.
Okay. So, because currently AB 1690 is not even in a committee yet. I mean, we're already halfway. So if I'm hearing you correctly, 1690 doesn't mean anything. I mean, we shouldn't read anything about what happens or doesn't happen to it for this year. Is that correct?
Yes. AB 1690 as a spot bill is basically an organizing tool. That bill is not going to ever move. And the reason for that is if we amended AB 1690 into a full bill, it would have to clear the assembly by the end of January of next year. However, if we introduce CalCare as a brand new bill and just ignore AB 1690, it will have until the end of May to do the same thing. So it gives us a lot more time if the bill is reintroduced as a new bill. So yeah, AB 1690 is an organizing tool, but it is not the bill that is going to be substantive. So don't bother reading too much into that.
Okay, and then I have one final question, but it's kind of a big one. So if I go and read AB 1400, will it show how this is going to be paid for? So as an example, you talked about the 3 million uninsured people who don't even have the money to pay for anything right now. Well, 3 million, 1,000 per person on 3 million is $3 billion. So that's $3 billion we got to come up with. So it is funding, are the funding mechanisms written into AB 1400?
No, not yet. And they shouldn't be. And I'll give you the specific answer why. And I'm also going to actually drop our financing flyer in the chat right now that goes super deep, not into specific financing options, but also the process of how you develop financing for a single payer program. So to kind of tell you what that looks like, financing for big proposals like CalCare are typically developed in parallel with the system itself. And that's done because if we were to put a specific financing mechanism in there right now, and the bill was amended to add or remove a benefit or whatever, then the financing number changes, and then you have to redo that whole thing. So the proper process for adding financing to a CalCare bill, because a key inclusion in CalCare's bill, if you look at AB 1400, there's a clause at the end that says that the bill does not take effect until it's fully funded. So aside from its governance structure, which doesn't cost much money to do, but the bill itself doesn't actually take effect until it's fully funded. So, and since you need federal support in the form of federal waivers to use federal Medicare, Medicaid, and ACA dollars towards the system in order to make it work, and you can't actually do those things until a bill is passed, what the process is you pass a CalCare policy bill. You then take that bill and go to the federal government and say, this is the proposal we want to implement. Let's negotiate waiver authorities that will allow us to use federal dollars. They will then negotiate with us and say, okay, we'll give you waivers for X and Y that will allow you to use X and Y dollars towards this purpose. That will then inform how much money the state needs to raise afterwards in order to make the rest of it. The federal government pays for roughly 50% of healthcare spending in the state of California. So we need to know how much of that we can count on being used to implement the system and how much the federal government will approve before we can add the specific financing. We have a bunch of ideas for different financing options. They're at the bottom of that sheet I linked. But which ones in particular are suitable and what percentages depends entirely on what the federal government has to say, which is why you have that clause saying that the bill won't actually take effect until it's funded. So that gives us time to pass the policy bill and then take it to the federal government and negotiate for those dollars. And I wanted to go a little bit more in depth because this is a very common question. How do you pay for it? And it's probably the single most important question because we know single payer works as a program. The question is what are the details of making it happen? And unfortunately, me saying that depends is not a suitable answer for most people, nor should it be. So I wanted to really dive into what the process of funding a single payer bill looks like. So you can know that we have a bunch of ideas, but ultimately it doesn't make sense to add them to a single payer bill if we don't know what we can count on from the federal government yet, if that makes sense.
Yeah. I'd like to just add on to that. So as a white collar employee, white t-shirt employee, what I expect is going to happen is that I'm not going to see anymore on my pay stub a deduction for insurance. That will go away. I am willing to probably see a new tax. And I fully expect that tax will be less than what I'm paying the insurance companies. So that's a win, right? The other thing the company I used to work at was our CEO was from Sweden. Since passed away, but he's a great guy. And he said, I don't know what you Americans are doing, but he did say this. He said that if we implemented a single payer plan, then everyone here is going to get a raise. And the reason for that is because a quality healthcare plan is part of our retention incentive as a company. It's how we retain good health. If everyone has the same plan, we need to up our game in some other way in order to keep good employees. So I'm totally on board with that idea.
Interesting. Okay, Coco?
So I guess my question is, I'm sure you've done the numbers in the assembly to get this bill passed. What are we looking at? What are our numbers for support or against, and who do we need to lobby?
That is a great question. So we don't know exactly because there are a lot of members who refused to say where they were. That's why we were very disappointed that the bill still didn't come up for a vote, even despite it not having support, because we would have liked to know those things. We have educated guesses, and we also know that there were a lot of people who were elected last cycle that were not there before. There's one assembly member who ran on supporting CalCare that replaced a Republican, for example. So we fully expect that there will be more supporters now than there were then. Is it going to be enough? I don't know. I believe it can be enough. I don't think we're wasting our time here. I think we're building towards something that can actually be a victory.
But you have, I mean, Gail Pellerin is for this because it's already been in the chat from Glenn. Yeah. So you have certain assembly members who are positive for this. You have an idea on who's like, not so much.
I can give you guesses, yes.
Yeah. So what kind of numbers are you looking at right now? Because that's basically all we have to go on. So for, who we need to lobby for and who we need to talk to about this in order to get this to pass the assembly, because that's the first thing we have to do if we seriously want to work on this project.
That's true. So there's one complicating factor here, which is the switch in assembly speakers. My normal answer to you would be to look at the current members of the Assembly Health and Appropriations Committees. They need to approve it before the entire floor does. But the problem is, it's very possible that we're going to have entirely new committees. In fact, I would say it's probable that Rivas is going to replace the entire committees at that point. So that's not particularly helpful advice right now. So what I've been telling people is everyone should call and make sure your particular assembly member and senator is on board. And then we'll have specific targets once we know what committees look like. Because normally our advice would be to focus on the committees, but again, we don't know what they're going to look like when CalCare is ready to move. This speaker transition has really thrown a lot of things off for a loop this cycle.
And does anybody, Glenn, do you know where Robert Rivas stands? Have you talked to Dominic for 7th District on where they stand on this?
I have not talked to Dom. I have talked to others who have talked to Assemblymember Rivas, Speaker Rivas, who has indicated general support without any sort of commitment, which should sound familiar to Ryan. But I would say to Ryan and the rest of us that although Speaker Rivas is not our assembly member, he is local to us in a very close way and knows a lot of us and invited all of us, I think, to his the word it's not coronation, but I don't know what the right I can't remember the right word, investiture, whatever they call that.
And then there's also his brunch next week, right?
Yeah.
In San Jose.
That's what we're talking about. The investiture already happened, didn't it?
Right.
Yes.
But the point is he invited all of us. So I think he thinks of us as being, something like his constituency.
But I mean, a lot of this is because Dominic has taken over
the region
7th District, so we should be able to talk to Dominic about this as being his staff person, his primary staff person, to find out, I mean, whether he tells us or not, I guess is the question. But I think the big issue is that if we want to put this forward from our little group here, and work on this, that the consideration would be, we need to start looking at numbers. Who supports, who does not support, and who do we talk to? You know, at e-board, at the conventions, and all those things, because that's how we politic. That's just what you do.
So I would like to suggest, based on Coco's suggestion, that Ryan provide me or, whoever the group with the answer to Coco's question by email, perhaps, so you can work up the numbers and work up the people. And then I'll take that to e-board, this group's e-board, and we'll discuss it there and then move it to the group. That seem reasonable?
That's fair because, and I think that we have to look at the big picture because I'm not part of Kaiser, but my husband's part of Kaiser, and there's consideration from the people from Kaiser that this is going to screw up Kaiser being a nonprofit and how that all works. So I think that the information stream to different groups of insurances needs to be much clearer because it's not happening. They don't understand. And I want to also say, just by the amount of people who are attending this, that people are like, oh, no, my insurance is fine, whether it is or not. That the full picture has not been brought to bear. So, I mean, that's my thought, is that I think all of us, whether we support it or not, have to get much clearer on what all of this means. Because just like what Tim brought up, it has changed. Ryan, you have brought up different information to us that what we had before COVID. It's like 150% more information than what we had. And in that, then we have to think of it as different, and we have to become more aware of all of its implementation and how to support Gail and Robert and John Laird and on thinking it through and moving it along if it hits all of those notes for us. Just a thought.
Well, part of it is in those documents that he dropped.
Right. Yeah.
Nancy, you got all of those into the minutes, right?
I'm also going to put a link to last cycle's AB 1400 bill text if anyone is interested in reading through it. Everything that I said in one way or another is in there. If you have trouble finding where it says certain things, feel free to reach out. But this is the bill text, and it's certainly a lot longer than AB 1690's one paragraph.
Right. Yeah.
Okay, got those. Great. Okay. Are there any other questions?
I'd like to thank Ryan for his time. Appreciate you coming out and spending some time with us. We're small but scrappy, and
these are the types of groups that are going to bring the win home. It's very important.
And
we'll share the video out as well, so hopefully again it'll get a little more attention for the people who couldn't make it. This is an irregular meeting time for us, so that may have caused a little bit of.
Well, thanks so much for having me. Glenn has my contact info if anyone has any follow-up questions. I'm always take emails and stuff. Otherwise, thank you all again, and hopefully I can work with you all again soon.
Great.
Thank you. Thank you.
Thank you.
Thank you. And that's great. Thank you, Ethan, that's saying John Laird was also the co-author of AB 1400.
Right.
So that's great.